Welcome, Dr. Rashid, and
thank you, Ahmed. Thank you, Dr. Ahmed, for the nice introduction. Thank you for the organizing committee for the kind invitation. It's a great pleasure to be here today في مدينة المصطفى صلى الله عليه وسلم. My topic today is about predicting histology and advanced pathology based on imaging modalities when you perform colonoscopy. My main objectives today is to understand how endoscopists can predict malignant colonic polyps, especially with deep invasions, and based on the endoscopic feature. We'll start with a case. There is a 50 years old female with family history of colon cancer who came to the clinic for screening colonoscopy. You scheduled her colonoscopy and she is at the endoscopy unit now, and your resident asks you a couple of questions. The first one, can we use any of the new modalities to detect or characterize the colonic polyps? And if you encounter a polyp, is there any way to characterize them and predict which one is malignant, which one is benign? The importance of these modalities, the new modalities, it's basically provide an accurate assessment for the polyps on the right time while you are doing the colonoscopy, and decide which one is hyperplastic, which one is the adenoma, which one has risk feature, a high risk feature with deep mucosal invasion. And that assessment could reduce the procedure time, could reduce the cost as well, and potential risk that Dr. Riyad mentioned. And more important as well, reduce the anxiety for our patient after resected polyp. Is it malignant or benign? So the chromoendoscopy, let's start with the chromoendoscopy. It refers to, when you do a colonoscopy, it refers to a dye with a spray catheter. You basically spray the lumen in order to see better, basically, and or characterize the polyp. It basically different than the tattooing using Indian ink, and basically usually you inject it submucosal for future demarcation, but chromoendoscopy you use methylene blue or indigo carmine diluted with saline, and basically using spray catheter to see better. It was initially introduced by Dr. Tad from Japan in 1977. It has not been widely accepted because it takes so much time and it has a learning curve as well. The technique, you need a staining agent, and the most common we use is methylene blue and indigo carmine, and you need a spray catheter. Basically, you could use anything. One of the common things that we use and also cheap is the glue tip from Wilson Cobb. Here is an example. As you see on the right side, there is a subtle lesion. When you use the chromoendoscopy, you better see a flat lesion here. It was time consuming, as I mentioned. It takes so much time, you need a learning curve, and this is where the need to find something else and easy to do. So, and here is the importance of electronic chromoendoscopy, which basically you press a button and it will give you the image of which similar to the chromo, basically, without spraying, without mixing. It enhances the mucosal surface and the blood vessels. It has different technology. We have narrowband imaging with Olympus. We have FICE with Fuji, iScan with Pentax, and blue laser image as well with Fuji. And sorry for the busy slide, but here is the different new modalities. Most common new brand, FICE, blue laser, and NBI. So the NBI basically stands for narrowband imaging. It was produced also in Japan. It seems everything is produced from Japan. So produced from Japan, the main goal to predict the pathology at the real time. And use different absorptive reflective properties. And here is another example of using the NBI. The other one is iScan. It's one of the new technology as well, made by Pentax from Japan again. It used the post-processing software to filter the image. It has 3 modes. The first one, service enhancement, and this is to aid the detection of the polyps. The second, to help the augment difference between the depth and mucosal surface, contrast enhancement, and the last is tone enhancement to define subtle lesion and mucosal irregularity. And here is an example with the polyp using iScan compared to the conventional chromo endoscopy. The other one is blue laser. Blue laser was introduced in 2013, and this is by Fuji. There is only few reports with the BLI, and according to the reports, it seems very good, more than 95% for non-malignant polyp less than 10 millimeter. And here's an example for the blue light. So you have new modalities. You are able to use them, but what is next? So you see the polyp, you use the chromo endoscopy. What are the features you should know? There are different classifications, and these classifications help you to decide which one is malignant, which one is hyperplastic, which one is adenoma. We have nice classification, Paris polyp morphology, and this is more with resectability, and Kudu-Pitt and Sano-capillary pattern. So the NICE classification stands for NBI, International Colorectal Endoscopy Classification, and it basically developed to accurately predict the smooth muscle deep invasion. It divides the polyps to 3 types: hyperplastic, adenoma, and deep submucosal invasion cancer. And here is the 3 types. Again, another busy slide. The first one is the hyperplastic. They basically divide there are few characteristics they use. So the first one is the color, and when you talk about hyperplastic, it's more similar to the background compared to a browner, little bit brown on the adenoma, but dark with submucosal invasions. The vessel, basically you don't see vessel with hyperplastic. You may see very tiny lacy one, but more brown vessel with adenoma and disrupted area with submucosal invasion. The surface pattern as well, you see dark white spots with adenoma, with type 1 hyperplastic, and oval tubular branched area as well with white area in the adenoma, but amorphous, irregular shape with deep mucosal invasion. It has very good sensitivity, 94% with negative predictive value, 95%. And here is the color, as you see, type 1, type 2, the hyperplastic and the adenoma. Here are the vessel, which you don't see or isolated small tiny one compared to the brown branched vessel with adenoma. The other one is the surface pattern. As you see, they're totally different in adenoma and hyperplastic. There is another classification made by Japanese group. Basically, they divide type 2 will differentiate high grade and low grade, and they use irregular pattern, and variable caliber. There is another classification as well, which called WASP classification. This is made by a Dutch group, and this is to add in the NICE classification the sessile serrated adenoma, sessile serrated polyp. Traditionally, the sessile serrated adenoma or the polyp was considered to be benign with no or very low risk, and considered to be hyperplastic. But lately, they found the sessile serrated adenoma carried 15 to 20% of cancer conversion over time with different pathway. So basically, they use the NICE classification with the surface, background, color as a first step, and then they add the four features of the sessile serrated polyp as a second step to differentiate. So they use the surface, usually cloudy cloud surface on the sessile serrated, with a smooth surface in the type 1 and type 2, irregular border, vague border, irregular shape compared to symmetrical shape, and dark spots inside the crypts compared to no dark spots. So this is the WASP classification. As you see, the first one was for NICE classification. The first, what is the color? The brown color, brown vessel, or oval tubular. Yes, this is adenoma type 2. No, this is hyperplastic. And then we have the WASP classification. They added the 4 features. After you answer the first question, then they added 4 features, and by answering these features, this is the feature of the sessile serrated. If you answer them with the yes, 2 of them, at least 2, this is likely a sessile serrated adenoma. This second classification we'll go through. This is a Paris endoscopic classification of the superficial neoplastic lesion. It was established in 2002. A group of endoscopists, pathologists, surgeons gathered in Paris, and they come up with a system or description. And this is mainly to help and aid with the resectability, either using endoscopy, using aggressive endoscopy like ESD, or refer to surgery. And they divide or classify to protruding versus non-protruding lesions. And as you see, like on the right side, the protruding lesions, pedunculated, semi-pedunculated, or sessile. This is usually what we deal with colonoscopy, and endoscopy usually is enough. But with more aggressive, the flat lesions, with depressed area, you may need to consider like AMR ESD. With ulcerated area, excavated, most likely there is cancer. So surgery probably the option. Depends on the stage of disease. And this is another slide with same thing, but the lateral spreading tumor for type 2A, the elevated. They divide it to homogeneous, nodular, elevated, and pseudodepressed. The third classification, this is Kudo pit pattern. This is described by Kudo and his colleague from Japan. That was around 1993. And it highlights the feasibility of using the pit pattern to distinguish a neoplastic with non-neoplastic. And as you see, there is a specific pit pattern when you use electronic microendoscopy or conventional chromo, and you see specific pit pattern. And type 1, type 2 usually non-neoplastic compared to the rest, which usually are neoplastic. And this is also with the pit pattern. If the first two just round or stellar shape, usually endoscopic removal, compared to the last one, no structural pit, and this is usually surgical. It was validated by Kudo in 1996-93. Initial study. They examined more than 2,000 patients. They found type 1, type 2 associated with non-neoplastic compared to 3 to 5, which usually neoplastic tumor. And there was agreement about 80%, 81% about the pathology. There was another meta-analysis that also examined the kudu pit pattern, and they include 20 eligible studies, more than 5,000 colorectal lesions. The sensitivity was up to 90% with 85% specificity. The last but not least, SANU microvascular pattern. This is another complicated classification. They use also the capillary pictures to basically divide whether this is benign or this is malignant, with feature of mixed capillary presence or absence. So the diagnostic yield of the using a new modality, there was a meta-analysis, examined 91 studies, look for the characterization, ability to characterize these lesions. They examined NBI, FICE, and they conclude all the techniques except AFI sensitive and specific, and could be used by trained endoscopists. The ESG guideline on advanced imaging also support using iScan, NPI, FICE for characterizing polyp less than 5 millimeter by expert. The American Society of Gastrointestinal Endoscopy, they offer similar support, but mainly for NPI. The detection is different. So that was for characterization. You find a polyp and you basically use these buttons to characterize it and see which one is malignant, which one is benign. And this is basically clear. They're helpful, good sensitivity, specificity, and you could use them. But what about using them for detection from the start? Once you put the colonoscopy, you press the button. Can we use that? So there was a 6 meta-analysis, and they conclude there was no significant benefit for using them. And this is for average risk. It might be different in UC with the chromoendoscopy. So, and for that reason, the ESG also did not support using them for detection. This is from ESG as well, and they, for the detection, use just high definition endoscopy for average risk. But when you have Lynch or sessile serrated polyp syndrome, you may use a chromoendoscopy. For ulcerative colitis, there is a big debate which one you should do, which one you screen, and that was with ulcerative colitis or IBD. It's it's a different topic, which conclude basically it may increase the risk, the detection rate by 2-fold, but you cannot do it for everyone. This is the bottom line. You have to select your patient carefully, especially with one with long-standing pancolitis, one with PSC, or someone with previous adenoma. And for the characterization, basically you could use it for everyone. This is the future, probably, and this is the fashion. And this is also by Kudu, I believe, or SANU, from this year. So it was a comment about artificial intelligence. So they're trying to not replace the endoscopist, but help the endoscopist by detection of the lesion. So it's still like under a process. There is big belief in this project. And it could prevent endoscopists from missing polyp. Dr. Riyad was talking about 20% with small, tiny polyp. So that could help, recognizing the polyp. But still, it's not at the clinical use. There was few studies published from the same group, several group, and they conclude more than 90% negative predictive value to distinguish small, tiny polyp. And this is the artificial intelligence. Basically, when you examine the colonoscopy, it highlights or spot the lesion. So probably we'll hear something about it with the next few years. And I'm at 20 minutes. Thank you very much now.